terms of how GPs can embed IBIS care into their usual care, we know that models of shared care are an effective and safe way of providing care to breast cancer survivors. And we know it's often actually the preferred model for many women. The model of IBIS is one where we provide information and resources through a survivorship care plan to support this model of shared care. So what will happen is that a case conference will be organised with the specialist cancer nurse and the GP and ideally the practice nurse as well, to actually talk through the details of the draft survivorship care plan. In that care plan, there will be information around the treatment, some of the management of possible treatment side effects that the woman may experience, and then clarify the roles and expectations of GP in this model of shared care. So that's a really core element of supporting this sort of implementation of this model of shared care, so that we clarify GPs' roles and that GPs feel supported with the information that they need to actually take on this role. So I think it's important to recognise that we're actually applying some of the sort of principles of good chronic disease management that GPs do for many other conditions, but applying it to cancer. So some of those roles are around the management of comorbidities as well, that we know may be exacerbated as a result of cancer treatments. But the other really core part is in supporting the sort of broader health and well-being of the woman after her treatment for breast cancer. So within the care plan, there will be some self-management goals that have been determined through a discussion with the specialist cancer nurse and the patient with breast cancer. And through those self-management goals, GPs can again play a key role in supporting the woman to achieve those goals. That may, for example, be through also referrals to a dietitian, to a physiotherapist or exercise physiologist, or to a psychologist. Some of those referrals can also be supported using existing NBS items through chronic disease and team care arrangements. So overall, we see that this is a really key and important role for GPs to take on in applying their skills that they already have in chronic disease care and applying it to breast cancer. In terms of women presenting with possible recurrence, we know that actually if a woman does experience a recurrence of breast cancer, then it's often the GP who will first detect that, and actually often between the planned follow-up visits. So again, this is using GPs' existing clinical skills and acumen to recognise the possible symptoms of recurrence. But of course, they will, as part of their routine follow-up visits within the shared care model, they may also be conducting a physical exam to check for signs of recurrence as well. So through the IBIS survivorship care model, it's really important that GPs know how to rapidly access specialist care, particularly if they are concerned, for example, that their patient may have signs or symptoms of a possible recurrence. So within the survivorship care plan, there will be specific information around how to access the specialist care nurse, and the specialist care nurse can then liaise with the specialist team to arrange a prompt review of their patient. So as part of the shared care model, there will need to be some clarification within that first discussion at the case conference as to who will be responsible for ordering the imaging and clinical examination, which forms a core part of good follow-up care. So within the care plan, there'll be agreement as to when physical examination and mammography is required, and whose responsibility it is to do that. Many GPs will feel quite comfortable doing this, and then the key role then is about how they then communicate back to the specialist team about the results of, particularly of imaging results, and so that the whole team is aware that the monitoring for recurrence is being conducted. So in terms of the future role of GPs in shared care, I think this is going to become an increasingly common role. There's now very good evidence that GPs can play a safe, effective and acceptable model, a role in shared cares of cancer survivorship for a number of common cancers. The evidence is very clear in breast cancer, prostate cancer, melanoma, and there's more recent work in bowel cancer occurring as well. And increasingly we're seeing this recognised within national and international guidelines that recommend that health services should be adopting shared care models to engage general practice more in the role of cancer survivorship.